Thanks. Good morning, everyone. And again, thank you very much for the invitation, but I really am grateful that we have the opportunity to talk about something that's really difficult to talk about, but I hope I can show you at the end of this talk it's really important that we do. Here are my disclosures, and probably something to talk about is the language in this area is constantly evolving, and so I will do my very best to use the most up-to-date trauma-informed language, but I do recognize that that is moving, and we're all still learning. So we're going to define what intimate partner violence is, how prevalent it is, why it's important to us as orthopedic surgeons, how do I help, and who can I help? So when we see a picture like this, we have a fairly clear gestalt in our minds. So this is a 14-month-old brought in by their father. A little missed last step is the mechanism. And we have a femur fracture in, arguably a non-ambulatory child. So this is a fairly pathognomonic fracture pattern and story that's concerning for non-accidental trauma. We think of that, we've been trained that way. But how about intimate partner violence? If I show you a distal humerus fracture in a 41-year-old mother of two, if you look into her history, she's previously had a distal radius fracture that healed with no complications. And her story is that a couple days ago, she tripped over one of her child's toys. We don't really necessarily have that same gestalt or that, warning flag go off in our minds. But it's really important that we start the conversation about looking into these patients' histories more. In this particular case, this patient actually had 4 fractures in the prior 5 years. This meant that she sought out orthopedic care 4 times, and unfortunately, the next time she was injured, she was admitted to the ICU with a severe head injury. So we're very good at treating injuries. We've spent days now talking about surgical techniques and debating best approaches, and that is absolutely critically important. But we also sometimes forget about the person. And I'm definitely not someone here to criticize because I am equally busy, and unfortunately this is a very common statement that we all make. I've got 2 ankles, a femur, this humerus, and a couple of wrists, and I have to get through that today in my trauma list. And so I hope today is just opening the discussion and really starting some of the conversation. So what is intimate partner violence? It is defined as any behavior within an intimate relationship, and that can be current or past, where one of the partners is exerting power and control, and this causes physical, psychological, or sexual harm to the other partner in the relationship. This is unfortunately extremely prevalent, so the World Health Organization has deemed this as a global health concern. And it's without doubt, 1 in 3 women worldwide will experience violence at the hands of their partner. This is very significant because, as I mentioned, there's often repeat injury. Access to healthcare is often much more frequent for these patients, and they can have a really long-term health consequences, including psychosocial manifestations, addictions, and things like this. Why is it important for orthopedic surgeons? Well, musculoskeletal injuries are the second most common manifestation of intimate partner violence. And so, unfortunately, one of the main red flags is that escalating violence or repeat visits to healthcare providers is actually the #1 predictor for intimate partner homicide. So how prevalent is this in your CAST clinic? I hate to tell you, it's right under your nose every day. And so this is a fantastic study that was published in The Lancet. This is the PRAISE study. This was a 12-month prevalent study across 12 different centers and almost 3,000 female patients in our CAST clinics. And what did we find? Well, 1 in 6 women who presents to a CAST clinic has previously experienced IPV in the preceding year. 1 in 50, which sounds like a lot. If you think about 50 new patients and how many days or maybe weeks that is, 1 in 50 of your patients are actually presenting as a direct result of intimate partner violence. And unfortunately, with these patients, only 14% of the time have they ever been asked. So there's a real opportunity here for us as healthcare providers. The CAST clinic, ironically, is actually an ideal setting because quite often we see patients at the serial follow-ups. We get to know them in a concentrated period of time, and they're usually not in acute crisis as they are in an emergency department. So we do have the opportunity. So how do we help? Now I've let you know that unfortunately this is very common. It's very important. What can we do? I would urge you to look into the Educate program. So this is an online multimodal program that has tremendous resources. It is targeted at orthopedic healthcare providers, and it really aims to give us the knowledge and some tools to begin the conversation in our clinics. Next, I would suggest getting familiar with your local resources, knowing what kind of resources, shelters, social worker support that you have in your hospital, and really get to know your social worker. The expectation is not for an orthopedic surgeon to deal with a disclosure, even be familiar with all the legalities, but it's important that we ask our patients and we raise some awareness. But our social workers are absolutely the frontline folks that can help us in these situations. So if this has really swung, the pendulum has swung to really talking to all patients. Domestic violence does not discriminate, doesn't discriminate based on socioeconomic status, even gender at the moment. And so raising awareness, normalizing the language in your clinic is really what we can do as a start. So when? This is hard. We're busy. We always have these overrun clinics. But if you can just build it into a routine part of your conversation as you would ask about smoking or health history, we're reminded that we do have to take a history and physical examination, so thank you for that. This is just part of that. And so once you do this in a repetitive fashion, it actually can become a quite consistent part of your practice, and it gets more comfortable as you try it out. It's best, if possible, in a safe and private environment. So if you have a clinic room where you're able to see patients one-on-one, that's ideal. If you really do have quite a bit of suspicion, a really great trick that I know a number of myself and my colleagues will use is our x-ray rooms, or casting, for example. And so that's a great way to get a patient in a safe and private environment to have a conversation. How about how to ask? And there's a lot of literature on this. I'm going to present two scenarios. I've just said we don't have the same pathognomonic fractures. We don't want to provide judgment. We really want to, try to normalize this and ask everybody. But if you're very suspicious, we'll say, there's lots of great evidence to actually suggest asking a patient directly is the best strategy. There's evidence to support the patients actually welcome being asked. If it's not suggestive and it's just a routine part of your history taking, just a general part of your practice is great. I've left a couple of examples here. I tend to say, unfortunately, violence in the home is a problem for a lot of my patients, so I ask anybody, are you feeling safe at home and in your relationship at the moment? Just like asking about cigarette smoking. So there are lots of benefits with starting the dialogue. Even if you're not receiving a disclosure at the time, it plants the seed, it lets your patients know you care, and they're much more likely to actually disclose when they're asked another time, perhaps even by another healthcare provider. So 2 more slides here, I believe. We want to talk about ending the cycle of violence, and this is the really difficult part. There are all kinds of screening tools for perpetrators of violence, people that are having difficulty managing anger, but they use very outdated language. They're excessively long. They're really not feasible in a CAS clinic setting, for example. So just a little plug, I have a master's student that actually just successfully defended her master's last week, and we're developing a screening tool for those that are trying to manage their violent behaviors. We worked with patients. We worked with those that are actually seeking out counseling for violent behaviors, and a whole host of healthcare providers through both the Canadian Orthopedic Association as well as the Orthopedic Trauma Association. And so I'm hoping that soon we'll be able to provide some language around this as well. Are your loved ones scared of you? Have you ever been so angry at home that you've had a violent outburst? And so we're really hoping that there's some evolving terminology, language, and tools for us upcoming. I'll leave you just with this. This is actually a client of ours that's seeking counseling for violent behaviors in his home. And they welcome this. They want us to talk about it. I think what you're doing is really important. And I think if I had seen a questionnaire like this 10 years ago, my marriage might not be where it is right now. So, thank you.